Good afternoon, or still good morning if you're joining from Queensland. Thanks for coming to this rural health seminar series, lunchtime series today at the University Centre for Rural Health. My name's Chris Williams. I'll be chairing the session today. Before I begin and introduce Ivan, I'd like to acknowledge the traditional owners of the land that we're meeting on today here, the Widjabul people of the Bundjalung Nation, and pay my respects to elders past, present, and emerging, and thank them for the care and custodianship of the lands here for the last 65,000 odd years and into the future. I was reminded today as well that it may be a difficult time for some people with the pending referendum, and so I wanted to acknowledge my thoughts to you going through this particular time and hopefully bring on the yes vote. So just some housekeeping for people on Zoom. Can I just ask to please keep your mic muted? The seminar is being recorded, so turn your video off if you don't want to show your face. And we'll have some question time towards the end. And I'd ask you to please use your chat function or unmute to ask a question. We'll have an online facilitator as well. So I'd like to welcome Ivan Lin to Lismore today. He's going to be talking to us about clinical yarning and a framework for communication in Aboriginal care. Ivan Lin, or Dr. Ivan Lin, is a senior lecturer at the Western Australian Centre for Rural Health. He's a specialist musculoskeletal physiotherapist working around the Jimbanu area or Geraldton area in Western Australia. Ivan's collaborative research aims to improve the management of musculoskeletal conditions, clinical communication in Aboriginal, remote and rural health areas. Ivan's a really humble guy, and he probably won't acknowledge that his work, at least in the musculoskeletal space, has been really pioneering from an Aboriginal healthcare point of view. So we're really lucky to have Ivan present today. Ivan.
Not what you're expecting. Okay. Absolutely. Is that better?
Thanks very much. Thanks for that introduction, Chris. It's really nice to be here, and I'd also like to acknowledge the Widjabul people. It's a real honour to be on this country here. I haven't been on Bundjalung country. I've only been on Bundjalung country on one other occasion, which was years ago, and it's just such a stunning area. I'd just really like to thank and acknowledge our traditional owners and being very aware of being here in place. I want to acknowledge the traditional owners, my colleagues, friends, the elders we work with, back on the Yamatji country, which is where I do most of my work in Geraldton in Western Australia. Very different country to here, beautiful in quite a different way. But it's lovely to be here. And some of the work I'm presenting today, or most of the work I'm presenting today, is based on the work of our team back in Geraldton and this area of clinical yarning. And I hope today to sort of give you a bit of an overview of clinical yarning, but hopefully we can have a chance then to have a bit of yarn about, perhaps how this might work here or not work here, or any questions. Just have an opportunity to open that discussion up as well. So just to start, and I should say, for those online, I hope if you do have any technical problems, I've got a few videos and audios to play. Perhaps type it in the chat and Hayley can come and hopefully help us address it here. Yeah. So this is these are just some of the people. The photo of us group up the top there, who's Deb Barmer, Wanda Flanagan, myself, and Trevor Pickett. We're sort of the legs of a current project to implement clinical yarning across our region. But all of these people have been involved, and I particularly acknowledge Dawn Bessarab and Charmaine Green, who've been really involved and real mentors and wise guides for me. So what I want to do is start with a bit of a video. And I want you just to have a look at the video, and then we'll talk about some of the things which perhaps work well in terms of communication and some of the things which don't work quite so well. It's about 3 minutes.
Oh, so nice to meet you. Yeah, thanks for coming in. And sorry about the wait. Yeah, it's a bit busy today. So what can I help you with today?
I just got, I think, like headaches in the back of my neck, and like kind of coming around the front here as
Okay.
well.
And have you had lots of headaches before?
No, not really yet.
Okay, all right.
Probably just been bad the last 2 weeks.
Right, okay. And what time of day? Morning, afternoon?
Like all of them, and then like morning and afternoon.
Okay.
Yeah.
And during the night?
Yeah. When I wake up, they're still there.
Uh-huh.
And yeah.
Okay. Anything else with them, like funny vision, vomiting?
So no, not really. No,
Okay.
nothing like that.
And what do you take for them?
I've just been taking Panadol, but it helps manage through the day, but like not really that well.
All right, okay. Have you tried Nurofen?
No, I haven't tried Nurofen.
Okay, all right, so we'll think about that. Good. Now, because you're new here, a few other things. Have you had any other medical problems before?
No.
Okay.
No.
Anything runs in the family?
No.
Okay, good. Operations?
No.
Allergic to anything?
No.
No medicines that you're on?
No.
Not for the Panadol. Okay. What work do you do?
I'm a truck driver, FIFO,
How long have you been doing that?
about 2 years.
Okay, good. Right. Oh gosh, sorry, a few things I've forgotten. Do you smoke cigarettes?
Yeah. I have been recently, so I quit about 2 years ago and hadn't smoked, but I took it up again a bit in the last month.
Okay.
So
All right. Yeah, we could look at that later.
yeah, should probably cover that out. Yeah.
And alcohol, do you drink?
No, I don't really drink.
Okay, that's good. Marijuana or other drugs?
No, I don't do any of that.
Okay, that's good. All right. It says here you're Aboriginal. Is that right?
Yeah. Dad's Aboriginal.
Oh gosh, who wouldn't have thought you were? Okay. And you play sports or exercise?
Oh, I haven't really been exercising a lot of recent, but I do usually. I do like to exercise, but yeah, haven't been able to lately.
Okay. So have you had a blood test in the last couple of years or?
No blood.
No? Okay. And what is it about the headaches that you're worried about?
Oh, just like they haven't been gone away.
All right. So what I'm thinking is that we check you out. So we're going to do your blood pressure, listen to your heart, things like that. I'll do a form for bloods because it's always good to check, you know, your liver, your kidneys and everything else.
Okay.
And if you can actually do it next door now, that would be good because we'll get the results straight away.
Yeah.
And for the headaches, I think if you actually had Nurofen as well, you can have Nurofen and Panadol together.
Okay.
Let's try that first, see how we go over a couple of days. You know, then you could book in again to see us at the end of the week and we'll have all your blood results.
Okay.
How's that sound?
Yeah. Will the bloods, they help with my headaches?
Well, they might show us some reason behind what the headaches are.
Oh,
So
okay.
we want to sort of rule that out first.
All right.
Yeah.
Yeah.
Okay.
Oh,
Good.
yeah.
Well, thank you very much for coming in.
Mhm.
All right. Okay. See you at the end of the week.
So can I start by asking what went well, what was effective in terms of communication in that consult? Yeah, fair enough. Do you want to start with what went not so well? Yep. Yep. Yeah, that's right. So she wasn't really attending to any cues around his body language. Computer was definitely a barrier. What else?
She asked a lot of those questions.
Yeah, it was very checklist focused. Yeah. Yep. What else?
Would there have been an introduction before he went in there about her name and where she was from and his, that thing?
It would have been good, yeah. Yeah. So perhaps the lead in introduction wasn't there. Yeah. Yeah. So incredibly judgmental. Yeah, and very off-putting, of course. Yeah.
At least she was thorough with that history.
Yeah.
A lot of questions.
Yeah.
Sometimes we got to ask a lot of questions because I'm just speaking from personal experience because I get the blood pressure stuff.
Yeah.
And of course I get the identity thing. At least you get to say what part of you average on.
Yeah. So
It was a lot of questions too.
yeah.
Sort of asking a few questions at the end. Question be like the answer.
Yeah.
That sort of stuff.
And did he look that happy at the end? No. You can see he's like, oh yeah, right.
Sorry.
Medical doctor. So what was good or what was more effective? If those watching online have anything, please feel free to type it into the chat and maybe Hayley can feed it through.
We scratched the surface of the timing of his headaches and I was getting into some of that.
Yeah.
Probably didn't take time.
Yeah. So maybe clinically, but it is a bit abbreviated because for the purpose of the video. Yeah. She's sort of pleasant. Yeah, like she's.
One thing that he kind of identified though, like he did say about his smoking, like we should address that again.
Yeah.
She just went, yeah, okay, later.
Yeah.
Which, like was an opportunity to open up that dialogue for what else is going on and getting back to cigarettes and that probably could have had something to say.
Yeah, so she missed those cues as well. Yeah, completely. Is that very different from a typical consultation you might see? No? Yeah. All right, thank you. I wanted to sort of just get you thinking about communication and clinical consultations, in that case a GP consultation.
Just a couple of comments from the chat.
Yep, thanks, Hayley.
Not much went well. No building patient report,
Yep.
No physical exam, no suggestion of x-ray or other things careless in manner, no human connection, merely a white clinician box ticking worker, lacking ability to build relationship. That was from Liz Ricks. And no check-in to see if understood from Morag.
Thank you. Thanks to everyone who commented as well. Yeah. 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 And again, there's lots of cues there, but nothing followed up on. Yeah, that's right.
Especially the stresses that they have in place.
Yeah.
Depending on what pace.
Yeah.
Mm.
And the stereotype around the redhead black hole.
Yep. Yeah, absolutely. There was a sort of almost an absence of the patient there, wasn't there?
Yeah.
You know what I mean? Like she had the list, she had, it's, yeah, thank you. Okay, so something else to this, and this is a story of a woman, a Yamaji woman, back in Western Australia, and her story raises some issues, I guess, from a person perspective. So have a listen to this and see what you think. We'll talk about it.
My name is Marilyn Papertalk. I come from Morawar, and our language is Morawar Wodjeri. Last time I went to the doctor was 4 years ago. I was pregnant, and they gave me all the tablets, like diabetes tablets, high blood pressure tablets, and they made me have a miscarriage. They just said, yeah, take it, whatever. And I didn't really know all the effects that would have come to my body, because I thought I couldn't have children. And yeah, I got a big shock when I did find out, and got a big shock when what happened. I was emotional. I even wanted to harm myself, and I haven't been there for 4 years. I just take the kids back to get their OBS checked because kids, and I don't take no tablets, nothing. I just started eating healthy, drinking water, came back to normal size. If you're a GP and you're trusting all your everything with them, and they're the only one you're going to talk to at the end of the day, because sometimes they won't talk to their other family, and they'll assume that the doctor is the best person that'll know what's wrong with me, and he will listen to me, like in that medical term. If they have a problem, he's the one who can be able to fix them. That's what they're there for, the GPs. Be pleasant, happy, and yeah, do them sort of things, because it'll make them feel happy to come in there to talk. But if you're going to give them that lodge and don't care, and they just don't give you eye contact, they're not got no time for you, this, you're in here, out, like that feeling. They're not there, they just don't do it for their job. They don't want to listen to me. Who's going to listen to me at the end of the day? Communicate, and you'll get a better idea and understanding of who that person is and what's happening with them. Break it down to how an Aboriginal will understand what the meaning is, and that you might get a person might not understand what they're talking about, and then they'll have to explain to, your heart. Things like that. They're like high words. Aboriginals don't know high words. Most of the people in general, they got renal disease, they will come out like that. I mean, what's that is? It's kidney. It's your kidney. Or they could say something else, you know what I mean? That they don't understand. Yeah, they break it down so they could understand. They do use high words. They should come to terms with the high and low and make it level to our standards, equal. You know what I mean? Because like I said, some people or most people don't understand what they're talking about. When I take tablets, they just say 3 times, and this is for your headache or whatever, what part was wrong with me. So I think they should explain a bit more, because sometimes they have to explain the side effects as well, not just how to take it, when to take it. And if you get noisiness, come back and let me know, they have to explain it properly, because some people might not even know what nausea means, if you know what I mean.
Do you think if you were to find a doctor who spoke to you clearly, treated you,
I will attend there. I'll go to see him, because he'll have more time and he's listening, he's opening up, and he's well aware of your situation, and he'll probably, if he can explain what my situation is at, I'll definitely go there every time. Yeah.
Sorry about the start of that. It was quite soft. But I'm not sure how much you heard of that, but it's a really sad story in a lot of ways. It's and you would have heard from Marilyn about, she was prescribed a medication, at least from what she understood about wasn't explained, that had some pretty terrible consequences for her, both in terms of, her physical health, her mental health. It's led to her disengaging with healthcare for herself. And so this, and the frustrating thing is that's something that is avoidable. If that communication had been better, that could have been a better scenario. And what we know from research in communication, this is an adaptation of one of Sam Bunsley's slides, I think. We know that communication issues in research have been covered quite well in terms of qualitative research. So we know the use of medical jargon, we know that mistrust of healthcare services, we know that experiences of racism, language barriers, and sort of different world views and conflicting sometimes worldviews between what patients need and want and what health services feel they need to provide has a number of consequences. And so this is the background for clinical yarning and where sort of where we felt that we would like to do something in this space, I suppose. And of course, the basis of that is that communication is the basis of everything that happens in healthcare. You know, there's a whole heap of advantages around communicating effectively. Yeah, so it's sort of like a no-brainer that it's something that can be improved, and it's something that's modifiable, as opposed to a lot of things which are less modifiable, perhaps. So this is Dawn Bessarab, Charmaine and Green, and I sat down about 4 years before this paper and had a yarn. Dawn, she developed a fairly seminal framework for research, qualitative work, research yarning, she called it. Charmaine and I were doing some teaching at that time of students in the university, and we had these groups of interprofessional students, and we found we were always prompting these students. These students were interviewing Aboriginal people, elders who were coming in and then telling their story, their health story, and the idea was around collaboration around student interprofessional learning and learning from these, what we call community teachers. And Charmaine and I found we were always prompting these students in not so much in what they were asking, because they were asking whatever it was from their profession, but the way they were asking it. So the process of communication was always sort of firing questions, and this person sort of seemed to shrink in their chair, you know, as they get these questions fired from all parts of the room. And so we had this discussion, and we talked about, you know, what we're really talking about is trying to get these students to have a yarn with the patients, make these community teachers feel more comfortable. And so Dawn was visiting Geraldton. Dawn is based in Perth, and we sat down with her and had a yarn, and we thought about how applicable Dawn's research yarning framework was for clinical communication. So I'm not sure if people heard of clinical yarning before? Yep. Okay, some have, some haven't. So really what it is looking at, instead of so as a physiotherapist, you know, like I have this whole lot of information that I would need to understand about someone who walks in if I was to understand what's going on with them and to be able to recommend anything. And so I've got this whole list of information. And so one option is to get all that information and then ask the person, say, tell me about your pain, tell me about what it does in the morning, what makes it worse, what makes it better. But, you know, on the other hand, you've got other ways in which you can collect that sort of information. And that's what clinical yarning is about. It's not so much the content, it's the process by which you communicate. And there are 3 parts which we'll go through. But before I do that, I just want to highlight, so Wanda Flanagan, colleague Wanda, who's a Nunuru Wadri woman, this is her interpretation of it. And just to highlight and to tell a little bit the way she conceives it, she painted this painting conceiving as the white being clinical spaces, sterile spaces. And she talks about what that smells like and this sort of thing. You know, on the top left, you have the healthcare professional represented with a white coat, and the patient or client on the right-hand side. And she talks about this sort of walking through this sort of journey together. And I think the thing that she highlights here is really around the fact that it's not linear. It's not sort of this way. It's this journey around all 3 different parts. And so what I want to do now is quickly just talk through those different parts. So the social yarn. So sometimes the social yarn happens at the start of a consultation. Often it does, or it might not. So someone walks in and you say, how's it going? And they say, for me, they say, oh, look, you know, the back's killing me. I'm not going to go, oh, all right. So what have you been up to on the weekend? You know, I'm going to say, you know, tell us about that. So it's following what is most important to that person at the time. And so the idea of the social yarn is really about developing the relationship and trust. It's about making that person feel comfortable. It's about understanding their life world and perspective they're coming from, but also allowing them to understand a little bit about where you're coming from as well. And it's also showing an interest in them as a person, as opposed to a health condition or a body part or something along those lines. Okay. So as I said, the social yarn often happens at the start, but there might be a cue during the consultation that you might then enter a little social yarn at the time as well. It depends on the person, depends on the circumstance. So what I want you to do very quickly now is just turn to the person next to you. This will be difficult if you're online, unless you're with people, and just have a 1-minute social yarn with the person next to you. If there's 3 of you, just have a little yarn in a group of 3, okay? Okay, do you want to wrap up your social yarns? You want to finish your social yarns? Sorry. Sorry about stopping that conversation. Thank you. Yeah, thanks. Geez, hard to stop you when you get going. Okay, so does anyone want to yell at? What did you have a yarn about? Family. What? Home. Yep. What else? Yep. Yep. What you did on the weekend? Great. What else? Oh. Hey. So how did you get to that yarn? What did you do to get to that yarn?
What have you been doing?
So you asked an open-ended question?
Yeah.
Yep. How else did you get to that yarn?
Start with our names.
Introduced yourself?
Yeah.
Nice, yeah. What else?
Check the body position, or basic color, or less important.
Yep. Okay, so you changed your body positioning. There looked to be a lot of smiling going on. Yep, which was nice, and a lot of nodding. Okay, so signaling to the person that you hear what they're saying. Sorry?
Found common ground.
Yeah, okay, how did you do that?
Just by discussing where it came from.
Yep, okay, so you talked a bit about yourself and, yeah, gave some context. Did you have?
I was going to say that you offer a bit about yourself first.
Yeah.
See how they.
Yeah, exactly. So, I mean, they're the sort of niceties of communication. And so we can break some of those down. It makes it a bit sterile, but, you know, there's what you're all talking about is skills around communication, okay? And so some of the skills, this is not an exhaustive list, but these are some of the skills that we think are probably more important to consider in the social yarn, and that includes things you've already identified. So introducing yourself respectfully, being friendly, open, interested, and you demonstrate that in verbal and non-verbal ways, finding some common ground, giving some information about yourself. When we've talked to particularly medical audiences before, we've had a little bit of pushback about that. You know, we don't share information about ourselves, we're objective and this sort of stuff. And of course, we're not asking people to share personal, sensitive information. It's more about sort of, you know, letting that person understand a bit about you. Yeah, so, you know, what did you do on the weekend? Oh, I went fishing. Oh, you know, how'd you go? Or, oh, great. You know, my kids love going fishing as well. You know, it's that sort of stuff. Humour's great if it's a suitable context. You know, attending to your body language. There is some research that talks about how long it takes people to make their first judgment of a clinician. Anyone want to hazard a guess of how long that sort of time it takes for a patient to make a first judgment of a clinician? Less. Less than 3. I think it's 0.3. So that's it's before you've said something. So if you're going into the patient saying, come on in, you know, that's, you know, so your non-verbal stuff is clearly important. It's probably more important, you know, culturally as well. Demonstrating awareness or interest about culture can be really good. Yeah, and one of the things also is hopefully already knowing when you need to consider working with an intermediary, a cultural intermediary, whether that's for interpretation or whether that's someone to help you bridge that. Yeah, questions about the socian? Is it common sense? Yeah. Oh, that's working with cultural intermediaries.
And so where do you find these cultural?
Well, that depends on where you work. I don't know. Can someone else answer that? Who lives in this area?
So it's like a cultural support person for the client, and you know, it's might be unsafe for them.
Could be a family work, it could be like in my case, I support lots of my family members. Hold hands when necessary. As an Aboriginal help work, if I'm provided in, I'll attend that in previous jobs, I'll attend that appointment with an agent. So, yeah, I mean, you know, yeah. Our families can feel uncomfortable attending centres or, you know, for what historical reasons and, yeah, I mean, bring up the Aboriginal health team to start, basic start, that would be a good starting point. Sorry.
And also an ED, without EDs, I should have an Aboriginal use.
We're pushing it out the moment.
So
if you're, so what, sorry, I want to ask more questions, right? About this, so maybe I should catch up. I just think, so I have a private practice and I work with kids and sometimes they're removed from home. They're under like a Casper or something. No, but I just wonder, like, what if, do I trust the ANS to get the appropriate support for the person? Like it's a matter of they're male or female and partner kids, you know.
maybe catch up for a yarn afterwards about that. But I reckon that's an important question. And you know, if you're in a health service, there may well be. I mean, ideally, there's going to be positions there to help, but it's tricky in private. Yeah, agree. Okay.
Ivan, just from online.
Yes, thanks.
I've turned these mics on and I'm going to bring them round to the audience for discussion because it's a bit quiet for those online with the floor mics. They keep dropping in and out. If you want to have one down there with you.
Yeah, thank you. All right. Well, quickly, yeah. So this is this very short video. It's only a little quick snippet. Have a look and tell me. We're going to. I want your feedback on this video about the socian. Okay.
G'day, Colin. My name's Andrew. I'm one of the physiotherapists here at the Pain Management Centre in Brisbane. So thanks for coming in today. How are you going?
Why, all right. It could be better, you know.
Yeah.
Back pain sore. Give me plenty of trouble. Pain. Come all the way down and down my leg.
Yeah. Sounds pretty uncomfortable. Can you tell me a bit more about that? You know, when it started?
Oh, I've been working since I was 15. Hard work. I crook back from time to time, but you become good. I hurt my back a while ago. Ended up having surgery, but bad ever since.
So what work were you doing then?
Fencing work, stock work, just working on farms. Hard work. It's the work I played hard too. I played league until I heard it then.
Okay, league. So you look like you could be a lock. I was a winger when I played league.
I'd be centre. I could run fast back then.
So you're a Broncos supporter?
Yeah. I have to go for Broncos because my dad got for Broncos. But I grew up in the States and Cairns, so I got soft spot for Cowboys.
Yeah. Okay.
So that's just a quick little social yarn. Whenever I play that in Western Australia, I need some explanation about sport. Okay. So this is a video we developed with our partners from QIMR and Queensland Health and Queensland University and others for a little project we did in Queensland. So what happened with the social yarn there? Tell us what you saw.
Sitting more open stance.
Yep.
And he asked when he asked, can you tell me more about that? So
Yeah.
he got him to open up a bit more.
Yeah, so he didn't start with a social yarn though, did he?
No.
He started with a diagnostic yarn because the guy said, oh, pain, So he said, tell me about pain.
You saw his moment to get in there as soon as the guy mentioned rugby league.
Yeah.
That was his moment to dive into the.
That was the little cue, wasn't it? And so then he went on and he shared a bit of information about himself. Rugby league, you look like a bit of lock, and then they had, So I guess, so that's just an example of a social yarn. It doesn't take long, and you can see the energy change quite a lot. You see that a bit in some of the consultations that we've filmed. You can see energy changes, the body language changes. Right, let's move on to the diagnostic yarn. So the diagnostic yarn is really about what I was talking about before. This is the information I need to gather. That's the information I need. And the diagnostic yarn is then the way you go about it. So instead of a tennis game where I'm firing questions at the patient and they're hopefully firing answers back, or in many cases, maybe not firing answers back, like that first consultation, the diagnostic yarn is gathering that information as a yarn, as a conversation. What sort of skills do you reckon that would then sort of encourage, or what sort of skills would be important? Thinking about those conversational skills, those communication skills.
I think probably early on you'd have to try and work out what their level of health literacy is.
Yeah, absolutely. Yep. And that's probably an overarching thing, isn't it? The way you want to interact with someone is going to be quite different. And I've been jarred a few times where I've started explaining something and someone stopped me very kindly and said, "Stop, Ivan, I'm a nurse." And I go, "Oh, sorry." Let's start again, and then reframe the way I was explaining things. So the sort of questions, what sort of questions might be favoured in a diagnostic yarn that we maybe didn't see so much in that first video?
While I'm passing the mic, a comment from Michelle Jack online, listening as a skill.
I was going to say asking, can you tell me more about this?
Yeah.
Or some of those more open, where you're inquisitive or you're wanting to know more.
Absolutely. Yeah, that's exactly right. So favours that sort of open-ended approach. That's not to say you don't have to, sometimes you have to be really clear about specific information, but it's about having that yarn and letting that person talk. So some of the important skills, open-ended questioning. Often healthcare practitioners talked about active listening, and we've had a conversation in our group whether or not it's about a bit more than that, maybe some deep listening, but certainly being non-judgmental is really important. Silence. Sometimes that promotes a really some reflection on some of the people we train, and they say, "I have really trouble with silence." But sometimes it's really important. Recognising patient cues, like we didn't see in that first video. Some of those reflective communication strategies, validating, summarising, prompting, clarifying. They're really nice reflective skills, and through that providing empathy and support for the diagnostic yarn. Any questions about that?
Probably more than just physical. We're looking at the whole person, so emotional, mental, spiritual connection to the community. That's all that needs to be included as well.
Yeah, absolutely. And if you let someone talk, then those important things often come up.
And a comment online from Liz, encouraging clients to use storytelling or narrative style, and also use of metaphor.
Yes, absolutely.
Just listening to the interview with the lady before, and she mentioned what her native language was. Just wondering what access to interpreting services might be available for all the different languages.
Yeah, I think that's very contextual. I'd probably throw to Veronica. She probably has more experience of different contextual areas.
Yeah, that's right. So very localised, and again, it's probably reaching out to the experts in the region, like Aboriginal Health Team, Virgil, or language centres. that exists around here?
I mean, I can only speak from our area. We've got common words and Aboriginal health workers would be pretty attuned to that stuff. But I guess places where Ivan's talking about, they have specific language speakers, and yeah, that would be able to assist with that.
Yeah, certainly interpreter services in some healthcare services, but yeah, perhaps not always utilised as well as they could be. Is not uncommon. Did you have something, Chris? Okay, no worries, thanks. All right, I'm just aware of the time, and yeah, so the last one is the management yarn, and the whole basis of the management yarn is that if you explain health information in ways that make sense, that are meaningful, then someone can then engage in their own care, you know? So you can't expect someone to engage in their care if there's no good reason to. And so that's what the management yarn's about. It's about sort of explaining information in a way that enables that person to be involved, and you can come up with a plan together. And it sounds simple, but you know, we know that it's not as easy as it sounds. And so some of the skills and that you talked about around that health literacy is understanding what that patient knows about their health issue first. Understanding what sort of information and what sort of type of language you might use. Obviously providing information in a way which is clear, it doesn't use jargon. We talk about using a variety of explanatory aids according to the person. So, you know, some people I would send them some information. You know, do you read stuff on the internet? Do you have an email? Do you use it? Can I email you something? You know, that might be completely appropriate. Sometimes it's using a story, using a metaphor. Often I'll get out a model of a thing and say, you know, and show a model of a body part if I'm doing that, and we'll talk that through, that sort of thing. Yeah, our team are involved in some work at the moment, developing some health information for Aboriginal people with arthritis. And so, you know, that's a process of culturally adapting information to try and make it meaningful, you know, so it's more understandable. And at the end of that, it's often good practice to do that talk back process. So when you go home, so, you know, you've come to me today and, you know, you've seen me because you've had this really sore shoulder. So when you go home and your auntie asks you, you know, what did he say? What are you going to tell her? You know, and then sometimes, you know, sometimes people say, yep, I'm really glad you took that on board. That's fantastic. Yep. Excellent. And sometimes people say, oh, look, we might just have to revisit that. It can be a good, you know, check of what you think and has been said and what hasn't been said. Yeah. So the management yarn. Questions about the management yarn at this stage? What we encourage people to do is sort of develop a bit of a bank of tools and like I don't know, arrows to their quiver according to the patient, have some resources they can send people online, which I think are appropriate. And so they can use these according to what that person's informational needs are and what the way they like to learn and the sort of things that would reinforce them for them. You know, it depends on the person. All right. This is a video, but I don't think I'll play it because I'm worried I'm going to run out of time. Sorry. So just quickly, so a little bit of, we probably haven't done half as much research as we should have with clinical yarning. We've been working quite hard on implementing it. So just quickly to show you some of the things that we've done. So on the left-hand side there, that shows, so we did a pilot study several years ago. This paper is currently under review. But it just shows the self-reported changes in communication skills, perceived communication ability, confidence, knowledge about communication and importance of communication training for people before and after. So the blue one is the before measure and the one on the right, the green, is the after. We use something that's called a retrospective pre-post. So instead of giving someone a before and after, you give someone something just after and say, now you've done it, what do you reckon you'd rate yourself before? What do you rate yourself after, sort of thing. So the idea is that people might not know what they don't know. So The one on the right is some figures from about a month ago we have an e-learning program. We're now about 1,700 people have completed our e-learning program. And this is just a level of agreement. This is one of the things, they all look fairly similar, and this is people rating its helpfulness for practice. The interesting thing on the left-hand side ones is that Aboriginal healthcare professionals, Aboriginal health practitioners, Aboriginal mental health care workers who've come along have also rated, have rated these things as well. So, yeah, it's good. This is a quote from some consultative work we did with healthcare managers and clinicians. And this particular person we interviewed also talked about the shortcomings in current cultural training. In WA, I don't know what it's like here, but it's very regionally specific. But the only other cultural training that was available was it was an online, like a 1 hour mandatory sort of online sort of workshop. So I guess in terms of summarising where the evidence is that we know, so we know that it's valued by clinicians. That's quite clear. We know that it results in some improvement in clinical communication behaviours by clinicians. What we don't know is in terms of patient experience and outcomes, and we have a project at the moment, an implementation project where we're trying to measure that and look at that. We don't really know how much training or support's needed. We have an idea, which we hopefully have a chance to talk about. Is it just one of those things it's a thread of part of the person's journey? Or is one thing if we do a workshop, can we expect that to be enough to make a change? We're not sure the best, how much is needed. I know that some of our partners in the UK, they run 4-day intensive sort of patient communication training skills sessions, that's pretty intense. But, people don't have the time to do that. That's what they tell us where we are. So, and implementation, what's the best way to implement that into healthcare? That's something else we're working on at the moment, and hopefully we'll understand a bit more in a little while, at least in our context, and hopefully there might be lessons for elsewhere. So I don't know if you've seen this website, but this is our clinical yarning website, and we have a e-learning program on that. It has a lot of those videos. I apologise if you've done it and you've seen those videos already. And you thought that looks familiar. If you haven't, it might be a good resource. We're quite clear. And in our e-learning program is that we consider this is the knowledge side of it. So what we know about training is that, knowledge is important, but if you want people to change what they do in clinic, they need to do it in clinic and practice it. So what we know about training is that what we think is important is, yes, people need to knowledge. So this has some knowledge stuff, but then they need to do some things locally. They need to get some feedback locally. They need to practice it, reflect, and do it again, preferably with colleagues, trusted colleagues. We have a co-facilitation approach where we have clinical staff deliver with Aboriginal staff. Obviously, these things aren't mutually exclusive, but we want clinical perspectives and cultural perspectives when we deliver any of our workshops, which are usually half-day workshops at home. Oh, and I should say as well, so that usually we have a cultural orientation workshop, which is run by Yamaji colleagues, and then the clinical yarning is something they would do afterwards, which is sort of like okay, how can we then turn that into like maybe some practice skills type workshop? So it's a twin approach, and that's the same approach we did with our Queensland partners around cultural capability is their framework. And finally, if you remember nothing else today, remember Wanda's painting and the 3 parts of clinical yarning, because it's a lovely painting. Thanks, and maybe we can have a bit of a chat now with the people online, plus people in the room, if you'd like to, if we've got 5 minutes.
Right.
Thank you.
I have a practical question from Clinton. Are the 3 videos shown in the presentation available online?
Yeah, 2 of them are in our e-learning program. Yeah, so if you go to that website that I put up before, then yeah, they're part of some of the learning modules in there, 2 of them. The other one's not. Questions, thoughts, comments? Yeah.
Thank you so much, Ivan. It's such wonderful content. I've lots of questions actually. And
3 minutes worth.
Sorry, I've got 3 minutes. I'll go to the stuff you're talking about, the diagnostic yarning. Diagnosis is fundamentally about answering what's wrong and how much of that or how much of something someone has. So and with pain, a lot of that is really uncertain. Right? So I'm wondering if you've got any advice about how to bringing that uncertainty into a diagnostic yarn.
Yeah, I mean, so the diagnostic yarn is mainly about information gathering from the person. So you don't need to make a diagnosis during the diagnostic yarn. Obviously, in the case of pain, for example, there's pain. There can be specific causes of pain, and there's a whole big group of conditions which are non-specific. And how we explain those, comes down to the way you would engage around that in a management yarn. What I normally do with for non-specific pain conditions is if excluded anything sort of structural, or then I usually map it out on a page. I sometimes write out the person's journey. So you told me 5 years ago you hurt your back at work, and that coincided with the time when you were really busy, you had a new child, it was really stressful, it was full on, but your pain didn't get better. And you told me that, when you're more tired and more stressed, your pain is worse anyway, but it sounds like you've been tired or stressed for a long period of time then. Does that sound right to you? And they go, yeah, okay. And okay, now you told me that before that you were really fit and you hadn't had many problems before. What have you done in terms of your fitness now? Oh, nothing. Well, I've been in pain. Yeah, you haven't. Why is that? Oh, because if I do too much, I get sore. Okay, but what about if you do a little bit? I haven't tried that. Okay, so let's think about that. What do you think? Oh yeah, righto. And so I tend to draw it as a journey sometimes. It depends on the person, and so it's that sort of collaborative process and mapping it out. I like that sort of process. Yeah, I don't know if that answers that, but yeah. Any other questions or comments? All right. If there's no other questions or comments and no questions or comments, hang on.
Just a couple
online.
from
Thanks.
Just from Michelle, thank you. It's a practical, actionable framework. It would be wonderful to see peer reviewed by cultural reviewers built into the peer review process for professional CPD requirements.
Yeah, absolutely. So as I said, any sort of, so this is sort of a taster. When we do any workshops or training, we have a co-delivery model back at home. In terms of, as I said, the online, the e-learning program is only the knowledge component. And so if you want to sort of develop those skills, then the practical component is important. We really think that peer review by Aboriginal and Torres Strait Islander colleagues is really important as part of that. So yeah, really good comment.
Just a lot of thank yous from online, lots of thank yous. And from Liz particularly, thank you for confirming my understanding of clinical yarning, such a valuable guide for clinicians and so valuable for expanding understanding across all healthcare environments and contexts.
Thank you, Liz. All right. Yeah, look, thanks for listening. Thanks for coming along today, and thank you for the invitation, Chris. And if you've got any, feel free to email me if you've got questions or, and for those of us here,